Advanced wound care is on the verge of its biggest disruption in decades. In 2026, Medicare plans to slash skin substitute spending by 90%, a $19.6 billion saving. Why the drastic cut? Spending surged from $252 million in 2019 to over $10 billion by 2024. To control these costs, CMS is rolling out sweeping changes affecting every provider and patient. We'll break down the two monumental changes, analyze the real-world impact, and show the collision between policy and technology. First, the new barrier to advanced care. Starting in 2026, Medicare mandates a 4-week trial of standard care first. This isn't just a waiting period, it's a performance gate. The wound must shrink by 50% to qualify for advanced treatment. The second change alters payment. CMS is ending payment for products based on their unique average sales price, or ASP. Instead, most skin substitutes will be bundled and paid a single flat incident to rate of around $127.28 per square centimeter. This flat rate payment applies everywhere, in hospital outpatient departments and in physician offices. No exceptions. So, 2 shifts, a clinical waiting period and a total financial overhaul. Now let's see why this is so significant for you. Why does leaving ASP matter? The old model paid different rates for products, reflecting their complexity. Advanced biologics were reimbursed higher. The new 127 flat rate treats most products the same financially. An advanced therapy gets paid the same as a simpler one. This pressures manufacturers. If their product costs more than $127 to make, they could lose money or exit the Medicare market. CMS is also tightening clinical evidence rules. Only products with peer-reviewed data proving they work will be covered at all. This is already happening. Oasis Trilayer Wound Matrix was removed from coverage lists due to what CMS called a lack of evidence. The goal is to cut costs. But what happens when these policies meet a non-healing wound? Could this backfire on patients? Consider a patient with a diabetic foot ulcer. Under 2026 rules, their journey begins with a 28-day countdown of standard care. But medical specialists warn, this mandatory delay creates a dangerous gap. Chronic wounds don't pause for a policy-mandated waiting period. If the wound worsens, the delay is catastrophic. It can become infected, spread, and lead to hospitalization or even amputation. This puts immense pressure on clinicians. They must document meticulously, knowing failure to hit a metric blocks needed treatments. The policy is a gamble. It wagers most wounds will respond to standard care, but the stakes for those that don't are incredibly high. Here's the great irony. These restrictions are coming during a time of massive innovation in wound care. The global advanced wound care market is set to grow from $18.9 billion in 2026 to over $60 billion by 2034. We are seeing AI-powered analysis, smart biosensor dressings that monitor healing, and new generations of cellular therapies. This creates a fundamental conflict. Science is delivering powerful tools, while the largest payer is standardizing payment and delaying access. So, will Medicare beneficiaries have access to this new wave of technology, or will policy create a two-tiered system of care? Let's answer our earlier question. Could these policies backfire? The evidence points to a significant risk that they will. The flat rate model, meant to fix the $10 billion spending issue, may stop the use of superior but costlier products. And the 4-week hurdle could actually increase long-term costs. Treating a severe infection from a delay costs far more than early treatment. The synthesis is clear. The push for immediate savings creates a system that may harm patient outcomes and stifle real progress. Approaching January 2026, wound care is at a crossroads. A market of technological possibilities on a collision course with rigid regulation. For patients, potential care delays. For providers, new burdens and hard choices. For manufacturers, a challenging new economic reality. Providers must prepare now, refining documentation to meet the 50% metric. Manufacturers must generate the clinical evidence CMS now demands. Understanding these changes is the first step. Preparing for them is the key to making sure that, in the quest for savings, we don't lose sight of healing patients.